All right, if you just joined us, this is Good Morning Nigeria, live on the network service of the NTA. And to begin our conversation this morning with what is on assessing breast cancer care and support, let's quickly take a look at this background report put together by our correspondent Oyeyemi Ajayi.
In countries with high Human Development Index, HDI, 1 in 12 women will be diagnosed with breast cancer in their lifetime, and 1 in 71 women die of breast cancer. While countries with a low HDI has only 1 in 27 women diagnosed with the disease in their lifetime, and 1 in 48 women will die from it. Breast cancer is a disease in which abnormal breast cells grow out of control and form tumors, and if left unchecked, the tumors can spread throughout the body and become fatal. The cancer cells begin inside the milk ducts or the milk-producing lobules of the breast. The earliest form, which is in situ, is not life-threatening and can be detected in early stages before the cancer cells can spread into nearby breast tissue known as invasion. This creates tumors that cause lumps and thickening. Invasive cancers can spread to nearby lymph nodes or other organs, and this is known as metastasis, which can be life-threatening and fatal. Treatment is based on person, the type of cancer, and its spread. The treatment combines surgery, radiation therapy, and medications. In 2022, there were 2.3 million women diagnosed with the disease and 670,000 deaths globally. Factors that increase the risk of breast cancer include increasing age, obesity, harmful use of alcohol, family history of breast cancer, history of radiation exposure, reproductive history, tobacco use, and postmenopausal hormone therapy. Approximately half of breast cancers develop in women who have no identifiable breast cancer risk factor other than gender, which is female, and age of over 40 years. Now, what more can be done to allow proper access to breast cancer care and support? A major question our guests will be answering shortly. All right, thank you very much, Oyeyemi Ajayi, for that background report. And let's get into this conversation on accessing cancer care and support by introducing here in the studio Dr. Omonisi Abidemi Emmanuel, Vice President, Nigerian Cancer Society, NCS, Research Committee member and representative of West African countries at World Health Organization's International Agency for Research in Cancer. Of course, that's via African Cancer Registry Network. He is also the founder and pioneer director of Ekiti Cancer Registry, as well as consultant anatomic pathologist. A pleasure to welcome you to Good
Thank you
Morning,
very
Nigeria.
much. A pleasure being here this morning.
All right, we have also been joined here in the studio by Gloria Ojinwa-Diogu, a breast cancer survivor, president, Network of People Impacted by Cancer in Nigeria. Thank you for coming on the program.
Thanks for having me.
Okay.
All right, also joining us for the conversation, we have joining us right here in the studio, Professor Musa Ali Gombe, Director, Clinical Services, National Institute for Cancer Research and Treatment, NICRAT. Many thanks for joining us, Prof.
Good morning.
All right, and also with us for the conversation, but joining us via Zoom all the way from Lagos is Professor Bello Abubakar. He's from the Department of Research, Development and Innovation, Federal University of Health Sciences, Azari. He's an oncologist. Many thanks for joining us, Prof.
Thank you for having me. And good morning.
All right, Professor Abubakar, I'm sure you saw me trying to pronounce the Azari properly, you know, just so that I don't get questioned. All right, so let's begin with you because your connection is clear at the moment. And I'd like you to just set a background for us. We're talking about breast cancer. That's our focus. Tell us, you know, the basics, what we need to know about breast cancer and what care is like in the country at the moment.
Okay, so thank you very much for having me. Suffice to say that breast cancer is the #1 disease in not only in Nigeria but across the globe. when it comes to female cancers. In Nigeria here, it accounts for over 22.7% by the Global.com estimate in 2020. And then we have over 18% mortality. And what that means is that over 75 to 80% of the patients that presented with cancer die of their disease within the first 1-2 years. And that is really alarming. So to say that breast cancer is not only a #1 cause of cancer mortality and morbidity, but it's also to say that it has also other connotations, such as socioeconomic, financial implications, and so on and so forth. Let me also say that breast cancer, being the #1 disease, should be seen as a disease of epidemic proportion. In other words, government, Nigerians should take it very seriously and look at what needs to be done. We do talk of the 4 pillars of cancer care. We said vaccinate those that need to be vaccinated. We said that treat those that need to be treated. We said that cure those that need to be cured, and then palliate those that need to be palliated. In most instances, most of our cancer patients actually fall in the last pillar, that is palliate only those that need to be palliated. And the real reason is because patients present very late. So late presentation is one of the real problems that we have. And you can't prevent really breast cancer because there are no vaccines yet for breast cancer. The only way is to have an early detection. So that is through the use of breast self-examination, clinical examinations, mammography, and so on and so forth. When you talk of all this, we are referring to screening, which has not yet been institutionalized in the country. We hope that in no so distant future, it will be institutionalized because it is part of the National Cancer Control Program that we have developed in the last 10-15 years. Why is it not institutionalized? It's because of funding. There is a lot of difficulties in terms of funding, and not only for screening, but also for cancer treatments, whether it is going to be chemotherapy, whether it's going to be radiation, whether it's going to be immunotherapy, whether it's going to be hormonal therapy, and so on and so forth. So there are a lot of concerns, there are a lot of issues surrounding breast cancer. And I must say that all hands must be on deck for us to be able to get out and reduce the statistics in terms of mortality. We may not be able to change the incidence, but mortality is one very key area that we really need to look at. Thank you.
All right, thank you very much, Professor Aliyu, for your opening remarks. Let's get back here in the studio while we will return to you a bit later. Let me speak with Gloria Ojunwajogu. Well, you are a cancer survivor, and I'm just wondering, what are the usual challenges that cancer patients encounter when they attempt to access treatment, care, support, whatever it is in Nigeria?
Thanks for the question. First of all, the first challenge is from the cancer patient himself, herself, though men also have breast cancer. So for himself or herself, first of all, the challenge is trying to convince yourself that it's actually breast cancer and that it is real. You know, a lot of people don't even want to believe it. Some people tell you you can wish it away. In fact, some people believe that by accepting it, it means you don't have faith.
You don't have
and
faith,
that is a huge problem. So the first struggle is from the patient himself or herself. Then when you're able to cross that hurdle, You now get into the government. I think the first one in terms of treatment and access to treatment actually is sometimes there are delays. You know, maybe when you go to the hospital, they have done the biopsy, they took the specimen to the pathologist, it may take time. And when it comes out, and one thing about the cancer cells is that it's not waiting for you. It may take up to like 2 weeks. And maybe by the time you get to the hospital, and you're to start treatment, the financial aspect of it comes on board. Treatment for cancer is not cheap. And sometimes we lose a lot of patients due to that. Because when you're given the list and how much you're going to pay for your chemotherapy drugs, and you check your bank account, you don't even have up to 50,000, and you're told you're going to take this chemotherapy, you may be having from 6 to 8 or 10 sessions, and they are telling you for one session you're going to spend like 120, 150, and you don't have up to 100. So many patients will just say, well, I can't afford it, they go home. But I'm glad there has been interventions, especially the Cancer Health Fund. It has really been helping patients to have that confidence that in spite of the fact that they don't have money, they can still go to the hospital and access care. So it has been a huge improvement. From the time I was diagnosed, that was in 2010, to now, there has been a huge progress.
All right.
Yeah.
Many thanks, Gloria Wajogo. Of course, I would like to hear more from you, as the conversation progresses. I want to know what it was like at the point where you were diagnosed and, what you went through, the procedures, up till now, and how you're defeating cancer, at the moment. Let's pause you. We have another guest joining us all the way from Lagos, so just quickly introduce her, Dr. Ada Enyi. She's the CEO, Oncopadi Tech, Sepsly Cancer Care. She joins us from our Lagos studio. Many thanks, Dr. Ada Enyi, for joining us. Joins us from our Lagos studio. Ada Enyi, for joining us.
Thank you so much for having me.
So we'll just let you settle down a bit. Let's continue with our guest right here in the studio before we get to you, Dr. Ada Enyi. So I'd like to get to Dr. Omonisi Abidemi Emmanuel now. I've listened to Professor Abubakar and listening to Gloria talk about, some of our experiences. Of course, we'll get details from her much later. But I want you to tell us, one of the main issues with breast cancer or all kinds of cancer that we experience is the late detection. Most times it's when it is an advanced stage that it is diagnosed, and then at that point it's almost too late. Tell us, what are the challenges really? Let's be specific, since we're talking about breast cancer for this particular episode. In terms of medical facilities, in terms of personnel in this field, in terms of, everything really, the environment, what is responsible for the late detection, which makes it almost impossible for the patient to survive, breast cancer? So that's what I want you to speak on.
Thank you very much. Well, the first opening statement I want to say is that breast cancer and other cancers are actually not, death sentence. We've heard from Gloria, experience, more than 10 years now, and she's still counting. Mm-hmm. We have survivors in the country, just I think 2 years ago, one of our survivors celebrated 25 years, of living in breast cancer. Why? Because it was detected very early, stage 1. The major problem we have in part of the world is that many of our patients present extremely very late. I mean, pathologists, we make diagnosis of cancers. Basically what we see in the hospital in our breast clinic are stage 3 and stage 4, advanced breast cancer. So in other words, they just come to the hospital, the best we can do is just give palliative, and which patients are the best. But compared to the Western world, where patients present very early. And why? Because they have national screening programs. But in most countries in Africa, there's no national screening programs. So people, just see breast cancer, of course, our religious beliefs also, their superstition. It's also a major problem. I was when a state, Kogi State, some years ago on medical missions, and we got there and somebody just mentioned to us that there's a woman in one room locked up, you know, that she has something like a boy in her breast. Locked up. Okay, we said, let's go. We went there. And we saw her. You know, it was a fungal case of breast cancer. But in that community, they call it boy. And we now started, you know, interviewing people at that scene. So, oh, her mother also died in this fashion 5 years ago. She has a boy in her breast, and that's how they managed, and she died. You know, and we you know, did, you know, our assistant to make confirmatory diagnosis. She has advanced breast cancer. And a few weeks later, she died. You know, so those are the major issues. You know, our patients present very, very late.
Is it just the fault of patients, and is it also the fault of government in terms of national screening? What about medical personnel, skilled personnel, you know, to be able to detect and diagnose patients with breast cancer? Because you go to some health facilities where people, you know, go and maybe when they're ill, and they don't have the facility to screen. They cannot check. So patients repeatedly go to the hospital and they are diagnosed with other kinds of ailments instead of, you know, what the main issue is. So is it just these two factors that you have mentioned? Is that really the problem in the country?
Well, that's not really the problem. As far as the human resource is concerned, I know in this country we have the capacity to manage, diagnose.
Even at the rural areas?
Well, basically in urban centers, yes, you know, and the major issue now is the gap between the urban and the rural areas. And that is one area that we think that, you know, we should play more active role. You know, NCS, for example, in that kind of society, we're actively involved as CSO. You know, that's why our campaigns, you know, is not limited to cities. You know, our member organization go to rural areas, you know, to educate the communities on easy signs, you know, early signs of breast cancer. You know, in the past, our concentration has been major cities, Abuja, Lagos, Port Harcourt, Ibadan, Ilorin, you know, state capitals. And majority of Nigerians, they live in the communities, in the villages, in rural communities.
But isn't awareness a problem? Because, I mean, for breast cancer, different from many other cancers, there is the privilege of self-examination. At least that could, you know, lead many to knowing that, oh, you know, to suspect that there's a problem. So if they do not know, then that becomes a bigger problem. Is awareness enough on the part of practitioners, caregivers, and the rest of them? That's besides, of course, government, the national screening, and then the patients presenting early when they actually see.
Yes, awareness is key because, you know, if you recognize an early symptoms, you know what to do. Again, superstitious belief, religious also a very major factor. I'll give an example. There was a professor. She was a professor. I'm not talking about literally, you know. She had this lump in her breast, went to a private hospital. You know, she was diagnosed, you know, but she denied, you know, came to a facility. So somebody referred her to me at her breast clinic, you know, examined, you know, also confirmed there was breast cancer, and I counseled her on what to do. The next thing, she went to Lagos. I won't mention the center there, to go and pray for 3 months. You know, and thereafter, she came back. By the time, you know, of course, I won't say her prayer wasn't answered, you know, but by the time I'm seeing her the second time, you know, I saw the tumor has advanced, you know, and not only then, she presented with left, you know, lump that was diagnosed, but surprisingly, it has crossed to the other side. Right. And she died, you know, 2 months later, a professor.
So, you know, for women, it is easy to diagnose. You can say self-examination, like Victor mentioned. But for men, how can you diagnose on your own? I'm curious.
Well, I'm happy that you brought the issue of men. Anytime we, you know, involve ourselves in campaign, you know, breast cancer, you know, and we talk about breast cancer, of course, it's commonest cancer. In Nigeria, it's commonest cancer, both male and female combined. You know, the leading cancer, more than 2 decades now, breast cancer has been the leading cancer in Nigeria, from you know, various data from the cancer registries. But we know that the men usually celebrate that they don't have cancer, but men do have cancers. In fact, in men, you know, it's more aggressive, and they die very early. Why? Because the breasts in the men are very rudimentary; they are not enlarged. You know, so once you have a lump there, it's an advantage because you can detect it very early. In the female, for example, they have big breasts. You know, sometimes because of the fatty nature, maybe to pick them. But the men, you know, so there's nothing there, just tiny breasts. Something's you should know. But the issue is that most men does not believe they can have cancer. They thought breast cancer is that of the female, but men don't have cancers.
Again, that becomes a matter of awareness. Anyway, let's
let's put you on hold. Let me get to Professor Ali Gombe. Well, you are of the National Institute for Cancer Research and Treatment. Where are we in terms of statistics, at least getting statistics, knowing what to do with the statistics and getting it to boost treatment?
Thank you. The National Institute for Cancer Research and Treatment, when we commenced activity last year, we realized that the most important thing that you need is actually the statistics. Without data, you will not be able to plan accordingly. You will also not be able to make projections and implement the policies as you may require. So first and foremost is actually to think about having a registry whereby all cancer information on patients can be fed into, which is centralized, which we have launched at the National Institute for Cancer Research and Treatment headquarters. What we are now trying to do is to feed the other hospitals and population-based cancer registries in and integrate them into the national system of cancer registries, so that we will be able to have data at a click. You'll be able to have all these information at a click. The hospitals, the population-based cancer registries have their own information, which can now be fed into the National Cancer Registry headquarters in NICRAT. And also, the declaration by the Minister of Health as cancer as a notifiable disease is now has made it compelling for any center or even if it is private or public that makes diagnosis of cancer to report to the National Cancer Registry, so that we will have adequate data that we can use for these projections.
All right. Thank you very much, Professor Lee Gumbe. Let's get to Dr. Ada Enyi now, who joins us from our Lagos studio. I'm sure you have been following the conversation when Gloria Nwajogu spoke earlier. She talked about the cost. That's been a major issue, but she says there's a bit of an advancement now. So I'd like you to talk to us, since you're into cancer care, about what care is like, for a patient with cancer. Just walk us through, the process, for someone who is diagnosed with cancer, what is available, what is expected, and what is the cost like. I'd like to hear from you.
Thank you so much for that question. So in terms of cancer care or cancer treatment in Nigeria, we've made a lot of progress in terms of the technologies and in terms of modern day treatment that is available. For one is that even though majority of our patients still present late, we are now able to offer, surgery for a lot of patients, who present early. We're able to offer chemotherapy to patients who also present early enough. We're able to offer radiotherapy and even as much as immunotherapy and some form of targeted therapy. And for a good number of our patients, previously there was no talks around palliative care, which was really not evident in Nigeria. But luckily now we have some centers who have now begun to imbibe palliative care as a form of care, understanding that a good number, in fact 60% of our breast cancer patients are, present in very advanced stages, so presents as advanced breast cancer cases, and so there's a lot of palliative care that is going in. But now, more importantly, is that when we talk about treatment, I would like to talk about early diagnosis. A lot of our patients or a lot of people are now better informed. There are more screening services that are now available. So many centers across Nigeria have mammogram, at least a mammogram or a breast ultrasound. Many organizations are now beginning to do, community-based activities like the Nigerian Cancer Society that is doing, community and rural-based activities whereby they go to educate people, they go to perform, or conduct some form of breast cancer screening at the rural stage. And so all of these advances are now making it better for a lot of our patients, to enjoy their outcome. More importantly is that we understand that a lot of breast cancer treatment comes down with treatment-related side effects, and now we are dabbling into technologies that enable our patients to report some of these treatment side effects in real time. And we have products like the ProScare app that help patients to do this. So we have a lot of technologies and we have a lot of advancements, but of course, in terms of the reach is still very limited, and I would say there's still a long way to go. More efforts can be made to increase this.
So, Dr. Adenyi, thank you very much for your opening remarks. We'll put you on pause and get to Professor Abubakar, who's joined us via Zoom from Lagos. Professor Abubakar, I'm just curious. Telemedicine has become a big thing in advanced countries, but how much role, can telemedicine play in improving access to breast cancer care in Nigeria?
So thank you very much. Yes, telemedicine has a very important role to play also in Nigeria, especially in the rural areas. But unfortunately, most of the telemedicine that is obtained at this point is primarily in the urban areas. You know that there is this disparity, significant disparity between the urban and the rural area, especially in sub-Saharan Africa and in particular in Nigeria, because a lot of education needs to be done to make people understand. You see, the truth of the matter is that we really need to go back to the drawing board. While we are trying to adopt technologies, we also need to go back to the drawing board and see how we can actually sensitize our people. How do they get aware? How are they able to accept the fact that cancer treatment is not a treatment that is primarily local? In other words, if you are coming from my area or from my village, to be precise, a lot of people don't even want to go to the hospital because they believe that, as they call it, Chiwan Daji, is not for the hospitals. So whether you're doing telemedicine or whether you are, sending all sorts of technologies, first the patient must accept that this is something that you need to go to the hospital and get treated. Yes, I know that there are quite a number of telemedicine that have made progress in Nigeria, like Mobi Health, I know is one of them. Oncopadi is another one. But the reach, especially when you look at northern Nigeria, for example, where you have, so many people in the rural area who are really, really poor and have not taken, healthcare as one of their privileges. It has not penetrated. And in all honesty, we haven't seen the effect really of technologies, telemedicine, and what have you. There are so much things that can be done, when you talk of telemedicine, not only for breast cancer, but even for other cancers. I'll give you an example of how you can actually manage cervical cancer using telemedicine. I went to Zambia, and there was this guy who has, gone to all the primary health care in rural Zambia. And what he does is that he trained the community health workers to examine the cervix of the women and take pictures, and then send those pictures to him real time. And then he, as a pathologist, gynae-oncologist actually, look at them and said, this one needs to be re-examined, this one is fine, and so on. So with that, he was able to screen over 200,000 people from the rural area. And these are the kind of things that we really need to replicate also in Nigeria. So yes, telemedicine can help a lot, but most of the telemedicine that is being conducted are primarily by people that have NGOs with not so much resources. I will want to see, for example, NICRAT unleashing telemedicine across rural Nigeria, because that is where the burden is. We don't even have the statistics. You see, when you talk of in Nigeria, we have this, in Nigeria, we have this. These statistics are primarily from urban areas, Lagos, Abuja, Enugu, Port Harcourt, and that is it. You don't hear the statistics coming out from the rural areas. And believe me, I know that by the time we unleash the gamut of telemedicine that we can have in this country, you'll be so shocked that even the statistic that we have of cancers, especially breast cancer, will be just the tip of the iceberg.
Many thanks, Professor Abubakar. Important to look at the rural areas. I hope NICRAT will respond to your comments there. But I'd like to get to Gloria Nwajogu now, because there's someone watching us at this time and maybe going through a case of breast cancer and has not been diagnosed medically. I want you to tell us, just take us back memory lane at the point where you were diagnosed, before you were diagnosed. What were the symptoms? What happened? Was it a prophecy? Was it a dream? How did you get diagnosed? And what was it like? Treatment. Just a bit. Try to summarize. I know it's a very long story, but just try to summarize and hit the points for us.
Okay. Actually, my journey started in 2009, and I do self-breast exam, especially when I'm having my bath. So it was something, yes, I got it through some awareness that I listened to, and I was like, okay, so whenever I'm having my bath, I do it. So when I felt a lump in 2009, I discovered it myself. I knew it wasn't there. So, and I called my friend, I told her, we went to the hospital, they checked it out. The doctor said, oh, we need to take it out and know what it is. And they took it out, took it to the lab. When it came out, I was told, oh, it's nothing, it's benign, it's nothing. And I was cool, I was happy. Then in 2010, June, almost like 6-7 months later, I felt another lump at the same place. And I also knew it was another lump because I couldn't, it wasn't like, I continued with my self-breast exam. So when I saw it, I said, no, this doesn't, even though it occurred where I had surgery initially, it's bigger. Yeah, it's bigger and it was getting harder. So I went back to the doctor. And when the doctor examined me, he said, Gloria is another lump and is even bigger than the first. And I can remember that day, it was horrible for me. I cried and I cried and cried. And after that, in fact, I had a premonition it wasn't going to be good this time. And so he still went ahead, took it out. Within that June and August, I couldn't get my results because one of the unions in the medical field was on strike. So I got it like 6 weeks later, and that was in August. And so I was right in the middle of writing my PhD examination when the doctor called me and asked me to come. I got there. I left the exam midway. I went to him. And then he said, well, Gloria, your result didn't come out as we expected. You have cancer. And I remember I couldn't cry. I was so much, in fact, I went into shock. My life stopped. And the next question I asked him was, doctor, how long do I have to live? He said, Gloria, who told you you're going to die? And I was like, okay, fine. I called my sister-in-law that is a nurse. I told her, she was the first person I called from my family. I told her, this is what I've been diagnosed with. So what do I do? She said, go ahead to the hospital and tackle it. And the doctor, because it was a private clinic, so the doctor referred me to National Hospital. And that was where I started my treatment. I need to say one thing, because there has been a lot that we talk about patients, breast cancer patients presenting late, most breast cancer lumps are not painful. So it is a disease you live comfortably with. It's not painful. You just feel the lump is there. You keep on wishing it to go away. Even when it's growing bigger, it's not painful. Maybe somehow when it has become strong, that's when you will be like, something has been here or disturbing me. So it's a disease that you carry around comfortably, living your life, being cool about it. It's mine twice. That I had recurrence in 2018. On both occasions, it wasn't painful. And so that's where I think awareness...
When you say lump, sorry,
Yeah.
you know I'm a woman too, so
Exactly.
I want you to explain to a young girl watching. For a young girl coming up, there's usually, when she feels her breast,
Yes.
there's some say some call it seed, some, you know,
Yes.
is that different from the lump, you know, that is cancer?
Now let me
Is it that the breast is supposed to be completely soft? Just explain to somebody who, you know, who doesn't know, who doesn't have an idea. Is it supposed to be free of nothing, just soft? You don't touch anything, you don't feel anything, just your nipple. What is it like for a breast that is healthy?
A breast that is healthy, like, let me come from this angle. If you have been feeling your breasts, and of course there are bumps, you know, in the breast, which is normal. When the lump comes, you know that this thing wasn't there before. So it's not as if the breast is completely free from lumps. And there is a lot of fat tissues, a lot of things that are there, which is natural. But if you consistently do self-breast exam, when something foreign comes, you will know. And that's why I wanted to talk more about awareness creation. We shouldn't stop. We should also go to the villages and create that awareness. I keep on telling my fellow women, nobody would know your breast more than you. Even some people that goes for physical self-breaks by others. If you don't know, if the nurse or whoever is checking you does not know how your breasts were before, she may even give you some level of anxiety, believing something was there, meanwhile there's nothing there. But if you as a person, as an individual, checks your breast, when something foreign happens, you will know.
You said it's painful, but so
No, I said it's not painful.
Sorry, it's
Listen.
not painful. You said it's not painful. So you don't. There are no, as in you don't feel dizzy, you don't feel hot.
You don't.
Nothing. There's nothing.
You're cool. In fact, it's the treatment that brings you down. Yes.
Oh, great.
And that's one of the things that discourages a lot of women. It's the treatment that brings you down. You will look so healthy and you walk into the hospital. And when you get your chemotherapy by evening, you're throwing up. Your hair, maybe in the next 2 weeks, your hair has fallen off. In fact, you completely change.
At the point of diagnosis, was there any form of counseling? Because you talked about, you felt, oh, maybe you were going to die. Did you get counseling?
I never did.
And do you think that is missing in the whole treatments?
It was, but I was lucky. I have a strong family background. And when I told them, they told me, Gloria, anything that can be done to you to make you be alive, that is what we want.
Okay, means she got support from her family. Doctor,
Yes,
I'd like to get to you. Because we're talking about care. And she talked about the fact that you are healthy until you get to the hospital. So, I mean, it's scary for anyone. And, you know, let's compare, for example, like HIV. At the time, it was a major issue. I know patients who were diagnosed with HIV had counseling. You know, they were just so that they don't think that it's a death sentence, just so that they can go through treatment and, you know, be fine with life. For those with cancer, what does it look like they are left to their fate once they're diagnosed? Tell us, what is missing? From what you said, I mean, there are certain things that are missing in the whole treatment process.
Yeah, when she was diagnosed, I agree with her absolutely, particularly in Nigeria, breast cancer management was not that organized. You know, but the structure we have on ground now, particularly in tertiary institutions, we have, you know, a team. Most teaching hospitals in the country now, they have what we call breast team. It's a multidisciplinary team where you have the pathologists, you have the radiologists, we have the oncology, you have the nurses, psychology, everybody is there. In fact, in most hospitals, they run what we call breast clinic. In my institution, for example, I think it's in the hospital, we have a breast clinic on Monday. At that clinic, we have the breast surgeon, the pathology arm there, the radiologist on ground, the nurse on ground. So the breast cancer patients, you know, we have moved beyond this general clinic. When she was diagnosed about more than 10 years ago, then it was general clinic. You mix everybody up in the breast, colorectal, intestine, everywhere. But
So
to be fair on Federal Ministry of Health, the state government and NICRAT now, things are better organized. They are better handled, from hospital, from point of diagnosis, point of treatment at all levels. You have counseling. In fact, there's even follow-up team. We have nurses, team that follow up to the various community. When patients are expected to come for that, they are not there. Phone calls are made. Sometimes vehicles are dispatched to bring them to the hospital. So what we have now in the country is far, far better. Because that was 10 years ago. Yeah.
That's soothing at least. But let me get to Professor Ali Gombe. Of course, I'm sure you took on board the comments of Professor Abubakar earlier, but I want to add to it so that you address both at the same time. Could more be done from your research and in your experience as an organization? Could more be done to make cancer treatment and screening part of the national health insurance coverage, for instance, because that could go a long way?
Okay, thank you very much. The problems are multifaceted, so also is the approach. We have been stressing on awareness, but if you look at the awareness itself, there is disparity in terms of urban and rural. In rural, even if you want to do technology to reach out to people, there are some hard-to-reach areas whereby you will not be able to reach out to them. So that also has to be done in a systematic way. One is, how can you reach out to them physically? That's the most important thing, because of inaccessibility to some of this modern technology that some of them even have networks, for you to reach out to them. So that will entail community engagement, both religious leaders, the community leaders, and also, going into the community to actually, do these awareness campaigns with them. The other aspect is also, most of these communities, they have access to primary health care. So the primary health care level is a very important point where some of them go to access care. So there is need for capacity building for the primary health care workers to at least detect that this, or suspect rather, that this patient has some form of cancer, be it breast or any other form of cancer, so that they can be referred appropriately. Now, even with that, there is also another aspect to it, and that is that, how do you navigate those that are suspected of having breast cancer to where they should receive their diagnosis and appropriate care. And this also can be done in several ways. Do you have mobile screening clinics that you can reach out to them at some intervals to screen those people? Or how do you navigate them to tertiary centers whereby they can have their diagnosis and also receive treatment if diagnosis is positive? And also the other aspect is leveraging on technology. We have to leverage on technology because Nigeria is a very vast country. We have a large population. More than half of our population are in the rural areas. So also the issue of the capacity workforce, the healthcare workforce. How many people do you have that can examine, diagnose, and treat those cases that are positive? This one is also where there are also very few pathologists. We have less than 200 pathologists in the country currently. And I know that that is a big issue. If you said that all specimens that you have taken has to pass through all the pathologists, that's the burden will be very much, we'll not be able, and if you go to a national screening program, of course, that will also pose a challenge because more and more samples will be turned out. And that is where we can leverage on technology to do artificial intelligence to select which ones the pathologists or the other doctors can review before, and then which ones there is no need for review, which ones can be handled by the people at the primary health care or secondary health care level, So those things have to be categorized, and this is what NICRAT is doing. We have, doing capacity building in various forms. Just recently, we did capacity building in terms of cervical cancer screening to primary healthcare workers and secondary healthcare workers across all the 6 geopolitical zones. The idea is we need to equip those primary healthcare workers to identify those diseases and treat the ones that they can treat and refer the ones that need advanced treatment. And also capacity building in terms of psycho-oncology. We mentioned something about diagnosis and counseling of patients. We have also done psycho-oncology training across the 6 geographical zones to healthcare workers so that they will be able to discuss, they are better equipped to discuss diagnosis of cancer with their patients. So another aspect of the whole issue is that you also need to have more equipment in terms of making those diagnoses appropriately. And what is observed is that it's better in most cases when these equipments are, they are taken to the people than actually waiting for them to come. So we are approaching it in 2 ways. One is you need to equip the tertiary center to make those diagnoses, and that is why we have launched the preventive oncology clinic, whereby you can walk into some of these tertiary centers to ask for some diagnosis, so some form of screening, of cancers, and also, now have a mobile screening van that can now reach out to some of these hard-to-reach areas, and then, make those diagnosis, or even take samples, bring back to the tertiary centers, whereby those diagnoses
Are these tertiary centers, are they screening free?
No.
Is screening free?
No, screening is not free. However, there are 2 ways you can do it, or 3 ways rather. You can make it completely free, but what we are proposing is to make it to be subsidized, or to maybe incorporate it into the insurance scheme. Yeah. Okay. So now, what is NACRA doing about insurance for cancer patients? Now, if you look at the national health insurance that we have now, even though I'm from NACRA, not from NTA, but all of us are aware that the coverage is, of those people that are under insurance, and also the resources that we need to take care of cancer patients is very huge. And also there is limited coverage on those people that are accessing the health insurance currently in the country. So what did government do? Government now have a short-term, medium, and long-term plan for the cancer patients. The short, medium, long-term plan is a fund that has been allocated, which is separate from the insurance scheme. It's called the Cancer Health Fund, which now NICRAT calls the National Cancer Health Fund, which provides free treatment free of charge to indigent cancer patients. That is the short to medium term. Now, as funding is provided adequately to the insurance, these patients can now move and be covered totally under insurance. So the National Cancer Health Fund was piloted in 6 hospitals, 1 in each geographical zone. The idea is to pilot, start with the resources that you have, and then learn from those, and then expand. The Honorable Minister has directed that the National Cancer Health Fund should be expanded to cover all cancer treatment hospitals, and it was piloted with 3 disease sites: breast, cervix, and prostate cancer, which are the most common cancers that we have. However, there is also now a directive to expand to all disease cancer sites, so as to include all cancer patients.
All right, thank you very much, Professor Ali Gombe. I'd like to get to Professor Abubakar now. Prof, talking about this, is, I don't know, but I want you to speak about what we can do, in the country, to make treatment, more accessible. Primary healthcare centers, like Dr. here already mentioned, we know the challenges with that, and of course, even in some rural areas, you can't even find as basic as that primary healthcare centers. And I don't know, how in your own opinion, what would be the way out of this, just so that more people do not continue to suffer, from this ailment that can be managed?
Well, that's a very big question, and Well, I'm not too sure if I'll be able to answer it, but suffice to say that one of the most important things that we really need to do is early detection. And to have early detection, you must create awareness. People must be aware, like Gloria has mentioned, you need to do self-breast examination every month, and usually if you are still menstruating, then it's advised that you do the self-breast examination 1 week after your period. At that time, all the lumpiness would have disappeared, from the effect of the estrogen during your period and all that. So awareness, you must be aware of your breast. People must take ownership of their body and be able to check. Then everyone must also go for clinical breast examination every month from the age of 25. One of the things that has not been mentioned is that there is a mutation that can be inherited, that will confer much more chances of developing breast cancer. And we have found out that about 20% of our breast cancers actually have that mutation called the BRCA gene mutation. And you see also, we talked about male breast cancer. So people that have, relations that have had breast cancer are likely to also have male breast cancers because of that mutation. So awareness, and that's the first thing. And the second thing is we must be able to institutionalize the National Cancer Control Program that has clearly defined the pathway of screening. We've talked about going to the hospital, clinical breast examination, breast ultrasounds, identifying very high-risk people, and of course mammography and MRI and so on and so forth. The primary health care centers must have a very important role to play. They must, and they are being revamped now because it's the only way. They should be able to do clinical breast examination and teach people how to do self-breast examination. Because if they can't do that, then I don't think we'll be able to make any headway. And I think that is why the minister is very key about revamping the primary health care. I think already they have gone further, they have gone ahead to really support the primary health care across the country. So one of the things, we have developed a DEX manual at the Federal Ministry of Health many years ago to educate the community health workers on how to identify signs and symptoms of cancers, especially breast cancer, so that when they see them, they will be able to refer them to the appropriate centers. That's the first thing. The second thing is that we keep saying that early detection saves lives. And I say that it is not true. It has to be early detection with early treatment, especially in breast cancer. Because if you detect it early and you can't have treatment, then, you are just killing the patient. So we must revamp, we must improve our referral patterns. We must improve our treatment centers. We have very few treatment centers. You'll be surprised to know that we don't have up to 10 functional radiotherapy centers in the country. This is a country of over 220 million people, and by World Health Organization standard, we're supposed to have at least 220 radiotherapy machines. So when you don't have up to 10 functional, then you can imagine the kind of difficulties that cancer patients go through. And drugs are very fundamental. Again, Gloria mentioned about the cost of the drugs. It has gone more than that. I'm sure you are looking at when you are having treatment. She was my patient, by the way, not anymore. She's cured. So the cost of some of the cancer drugs are really, really prohibitive. I can't afford it. You can't afford it. No civil servant can actually afford it. When you look at her two types of breast cancer, it cost about 2 million.
Professor Abubakar, I'm sorry we have to interject at this point to put you on hold, just so that we could take a break and pay some bills. We will get back to you, but when we return in the meantime, I would like to get to Adenyi, who's joined us also from Lagos. Please stay with us. All right, thank you for staying with us on Good Morning Nigeria as we tackle the issues around breast cancer. Now let me get to Adenyi, who's joined us from our Lagos studio. I'm just wondering how we might deepen awareness to tackle issues of stigma and misinformation, usually around breast cancer. Plus, are there recent advancements or affordable treatment options that we can implement in Nigeria?
Oh yes, absolutely. And thank you for that question. There are affordable treatment options that we can implement. For one is starting with early detection. There are a lot of NGOs, there are a lot of charity organizations that actually offer certain discounted services that can support some of the screening services. Now, just as Prof has said, most of the treatments are very, very expensive. A lot of patients can't afford it. Many of us, even I myself, can't afford it. Many civilians can't afford it. Even in the private sector, some of them cannot afford it. But they had discounted. Some donor agencies have come together, have collaborated together to actually support. One of the things we do at our center is that we offer what we call the Breast Health Friday, whereby we offer discounted services for these, up to 50% discount on, things like mammograms, ultrasounds, and a lot of the screenings, even genetic testing that actually helps to test about 10% of the population that have the BRCA gene. So that's also very important to note. Another way we've also been able to support, or another way we can also contribute to reducing or contribute to helping the treatment burden, is in programs and initiatives that actually diversify and strengthen the already limited resources. And I'll give you an example. We know, for one, and just as Dr. has said, Dr. Lingome has said that there is less than 200 pathologists in Nigeria. It's even worse to note that there are less than 100 oncologists in Nigeria. And so we need to begin to see ways that we can strengthen our primary healthcare centers, we can strengthen our primary care physicians to actually support in some of these treatment modalities. For one is capacity building. And so for us, we have what we call the StarPipe project. And StarPipe is standardizing the accurate reporting for patient treatment side effects, where we actually train a lot of these primary healthcare physicians, and the goal is to train more than 50 primary healthcare physicians and actually contribute to about over 1,000 patients actually being treated and being managed by these primary healthcare physicians to sort of reduce the cancer burden and also contribute to treatment gains that can be made. Lastly, would be centered around technology. I know that Prof talked about telemedicine, and I know that telemedicine has a huge role to play. For us at Oncopadi, we know that we can be a driver of cancer awareness, we can be a driver for cancer detection, and more importantly, we can be a driver for cancer treatment if we are able to plug into a lot of the primary healthcare centers that are available, so that we can strengthen capacity, we can strengthen our already depleted resources, and we can help holistically to actually help a lot of patients present early, help a lot of patients understand their symptoms, help a lot of patients to provide things like counseling and psycho-oncology that we've talked about, which already our specialists are very limited, but we can empower, other specialists or other doctors that can actually support in these. Thank you.
All right. The awareness part, of course, is a major issue, and then you ask yourself, are the agencies who are supposed to do that doing enough? you know, I expect that we should have jingles, posters in different languages. I mean, we shouldn't breathe when it comes to hearing messages on cancer, and specifically breast cancer, which is, you know, the major burden for us in the country. But, you know, I want to get to you, Dr. Omonisi Emmanuel, to talk about prevention. I don't know if it's if there are things, you know, whether lifestyle or I mean, are there ways? Because, you know, talking about this cancer thing just shows that if you have it, you have a problem technically. We talked about lack of adequate personnel. I mean, the facilities are also not, it may not be accessible. Imagine somebody living in one village having to access the national hospital, for example. I mean, the cost, everything. It's a terrible situation to be in. But is it possible that lifestyle could trigger it? I just want to know, or is it something that, like some say, is supernatural? It just comes from specific people, you know, irrespective of whether you do the right thing or not. Doctor?
Yeah, talking about prevention, I think the first thing I would like to say is we must accurately assess the cancer burden in the country. Because Professor Rigombe mentioned the effort of NICRAT to do that. I know that Federal Minister of Health, when they were hosting the National Cancer Registry, and in fact, since the day of IHBN, led by Professor Clement Adebamawo, you know, a lot of effort have been done to assess the cancer burden in the country, because that is very important. You know, I'll give you an example. In the 70s, in Nigeria, same in Nigeria, breast cancer wasn't a major problem. Then we're talking about liver cancer, you know, as being the lead cancer. You know, but now we're talking about breast cancer. In fact, you know, suffice for you to know that in the 90s, it was Shitu and Ogumbe Eto, University of Ibadan, that they assessed the cancer registry data, you know, from Ibadan Cancer Registry, and discovered that, oh, that liver cancer is not really cancer in me, that prostate has overtaken liver. And since then, that discovery, in the early 90s, till date, prostate cancer is the most common cancer in males.
It's dynamic.
So we must assess the cancer burden to be sure that breast is still the most common cancer. And that's why we must commend NICRAT, you know, current effort to strengthen the National Cancer Registry Network. A lot of training have been done by NICRAT, you know, to ensure that, you know, we have more cancer registry. As we speak now, we have 44 cancer registry in the country, in all the geopolitical zone. You know, they are doing effort, the national effort now, because I'm part of a member of that committee, to have a dashboard. Once you pick up a cancer at the rural area, it will eat up at a dashboard here in Abuja. So, NICTA can give you real-time information on breast and all cancer in the country. You know, that is what they're about doing. You know, so we must assess that. Number two, as we have said, health education is very important. And we must comment as CSO, you know, I'm the vice president of the Nigerian Cancer Society. We have done a lot of work in that regard. You know, compared to many years, go to the rural community now. People know about cancer. It's not because government is doing that. It's not government. It's Nigerian Cancer Society and the CSOs. We have all our member organizations, all the local governments in the country, all. You know, Gloria, she's leading, you know, one of our CSO, you know, leading a group. All. There is no local government in Nigeria that don't have cancer, footprint of the Nigerian Cancer Society doing that. So our men are everywhere, you know, and the education is not speaking English, no. If you're in a community where they speak Kanuri, they speak their languages. So we've gone to that extent. And what we're trying to do now is to partner with NICRAT and Federal Ministry of Health to have you know, publications in local, you know, language, not English and Yoruba, no, or the Hausa, no. They are, you know, supposed to know in some states, you may have more than 20 tribes.
No, of course.
There. So our plan is to partner, you know, with, you know, government agency, relevant government agency, you know, to ensure that we have, you know, publications, you know, handbills, you know, we have inscriptions, you know, in all our dialects. So health education is very important. Then the next one is what we call rainbow diet. You know, I'm sure that because of the economic hardship now, people just grab what they have. But what we recommend what we call rainbow. You know, rainbow have many colors, 7 colors. So any meals that you are eating that is not having 7 colors, there's a problem there. You know,
What are these colors?
green, vegetables. Red, tomato, pepper. White can be gari, can be rice, can be anything. You know, so we encourage people to eat rainbow diet. particularly fruit and vegetables. Why? Because they're antioxidants. You know, I'm a pathologist. One of the pathway of cancer development is through this is what we call free radical injury. So, but there are antioxidants that can, deal with those free radicals. Yeah. So we encourage people to eat fruit and vegetables. Through that, you generate enough
to boost the immune system.
Is it true that breastfeeding could also make you free from breast cancer?
Those are what we call, some protective effects. A lot of studies have been done on that, and yes, that also has confirmed that. That's why we encourage breastfeeding mothers to ensure that they exclusively breastfeed their baby. We know that our new generation mothers does not like that. They just put baby for 1 or 2 months and they migrate to infant formulas.
All right.
We encourage exclusive, breastfeeding because that also protects.
We're running out of time. Thank you very much, Dr. Omonisi. Let's quickly get to Professor Abubakar, who's joined us via Zoom, as we gradually round off this conversation. I'd just like to know, are there resources that should be made more available to support those who are going through the journey of treatment, to make it easier for them? And that's not just financial now.
So, yes, I think the Director of Clinical Services of the NICRAT has mentioned the Cancer Health Fund, the National Cancer Health Fund now, which is government-supported fund. The original of that is that government will put in some money, and then we'll also get some philanthropists to also support that fund, so that it's not exhausted. Unfortunately, the philanthropists, the other people have not actually participated actively. So because of that, that fund is just at the mercy of the federal government of Nigeria. So I think philanthropists, people of good means, should actually create a kind of fund in every hospital, in every teaching hospital, to support cancer care, because that is the only way. I mean, government alone cannot do it, but government is also trying. I do know that screening, if you are registered with the National Health Insurance, screening is free, for major cancers, breast cancer, cervical cancer, prostate cancer. That is part of the National Health Insurance scheme. Okay, so that is one thing that people should try and access. And I do know that with the establishment of the National Health Insurance Authority, every Nigerian is supposed to key in. So by the time you do that, then you'll be able to have a free screening program in the country. That is one. The other thing is state government and local governments must also come into play. It's only federal government that is now supporting cancer care across board. There is no harm in state governments creating hospitals, creating departments in teaching hospitals to support cancer care. I know that Lagos State is doing that. Lagos State is establishing cancer center in Lasut and many other centers as well. So other states should also try and do the same thing. I know also that Kebbi State have a kind of fund that used to support cancer care, Niger State as well, but I don't know about many other states. So yes, there are a lot of things that can be done to support patients, especially philanthropists. I think Nigerians should really understand that cancer care is very expensive. This is the cost of drugs are prohibiting, and many people can't afford it, and they should come to the aid of our patients.
Come to the aid of patients. Prof, I'd like you to just make some clarification, because now that we have said it's expensive, the drugs and all that, a lot of people also think that cancer generally is the disease of the rich. So I'd like you to come from you. Is it that cancer affects just the rich? And then, is there a particular age bracket that is exempted from this cancer issue, especially that's the breast cancer now? Some will say, okay, before 25. Some will say, well, after, once you stop menstruating, that you're free from breast cancer. Please, I want you to clear these myths.
So, on the contrary, cancer is actually not just the disease of the rich, it's also the disease of the poor. And in most instances, the rich can afford treatment, but the poor people cannot. And the chunk of our patients that we see are really indigent patients. They can't simply afford to eat 3 square meals in a day. And so it is a myth. It is not true that cancer is for the rich. It is really for the poor. And that is why they need the support. And that is why the federal government created the National Cancer Health Fund, because they know that majority of our patients are indigent patients that cannot afford treatment. So it is not true that it is only for the rich. And I have mentioned there are some breast cancers that you can actually inherit, as a result of mutation. And it is not only breast cancer, prostate cancer, pancreatic cancer, and so many can actually be inherited. So you don't need to be rich or poor to inherit those type of cancers. And we also have childhood cancers. These are cancers that are found in children. You see, so, and they are really, really neglected because there is no much awareness about them. And people, I know that NICRAD is trying to develop even guidelines for the treatment. We have also developed guidelines at the level of the African Cancer Coalition, where you can effectively treat childhood cancers. So there are cancers. So if you talk generally of cancers, there are cancers in childhood. Some are actually literally in quotes born with them. Okay, there are some kidney cancers that you detect in children. Usually the mother will present with the child in the hospital that his abdomen is growing. And then when you run some scans, CT scans and so on, you will see that the kidney is enlarged and so on and so forth. Those are diseases, they are cancers that they are really treatable if detected, at the appropriate time.
All right. So Professor Abubakar, I would like to thank you very much. Unfortunately, we are running out of time, and we just have to get back here in the studio. But we appreciate your comments coming from that end. Now, Professor Ali Gombe, I just wanted to find out if there are policies that should be in place to increase the availability of trained oncologists and specialized healthcare staff, particularly in rural areas. And this is against the backdrop of, the paucity when it comes to the number of personnel for breast cancer treatment.
Okay, all right. Thank you for this question. Of course, there is paucity of healthcare workers generally, not only in terms of oncology or in terms of breast cancer services in the country. The few that we have are also living for, so to say, greener pastures. However, this is one of our priorities as in the Institute, is how do we train and retain this workforce. So what have we done? Prior to, sometimes in September, we had the NICRAD NSIA Oncology Summit. The main theme of that summit was on workforce. So also the recently concluded ongoing International Cancer Week, which is going to be concluded today, is also has as part of the sub-theme workforce. And what we did was in the NSIA NICRAD Summit is to bring all stakeholders that are involved in training of this workforce and also international collaborators to discuss how do we train more and then retain more.
All
so
right.
There was an invitation for NUC and postgraduate medical colleges and also the civil service, head of civil service and other...
Because of time, Prof, thank you very much. I'm sure we'd have... it's a continuous conversation, actually. I'm sure we'd have another important one, episode to talk about all of that. Gloria, but before we go, just in 10 seconds, what would be your words of advice to someone going through breast cancer at this time?
I'll tell her, go for treatment. Yes, the treatment may be painful, but it's a phase. and it's going to pass. And they should also link up to some patient groups. Like my network, we are made up of over 300 patients. So we navigate ourselves. We tell ourselves, we give peer-to-peer support. Like just yesterday, day before yesterday, someone reached out to me. She had bilateral mastectomy, that's the 2 breasts we're taking off, and she was already depressed. So someone referred her to me, and I had to pick another person who had the same bilateral from my group to like talk to her. So we do that so that we can, you know, pull ourselves with the cancer patients out of the depression that comes with.
You're not a cancer patient, you're a cancer survivor. Thank you so much, Gloria Ojiwajogu, a breast cancer survivor, President Network of People Impacted by Cancer in Nigeria. Many thanks for, coming to share your experience with us. We do sincerely appreciate it and wish you the very best.
Thank you so much.
And good health, of course, going forward. Doctor, thank you so much for being our guest. Dr. Omonisi Abidemi Emmanuel, Vice President, Nigeria Cancer Society, Research Committee member and representative of West African countries at the World Health Organization. It's a long list, but we do not have time. Thank you so much for being our guest. We, of course, appreciate your insights. And yes, Dr. Ada Enyi, COO, Oncopadi Tech, thank you so much for joining us from Lagos, and we hope that you continue to do what you're doing. And yes, the discounts, very important. Professor Bello Abubakar, Department of Research, Development and Innovation, Federal University of Health Sciences, Azare. Thank you so much, Prof. It was good to see you again today. And yes, continue to do the good work that you are doing. And of course, I'd like to appreciate Professor Musa Ali Gombe, Director, Clinical Services, National Institute for Cancer Research and Treatment.
Thank you for having me.
Thank you for being our guest. All right, so that's our package this Friday. And good morning, Nigeria. I'm Henry John. Enjoy your weekend.
And I'm Victor, as always, see you again on Monday.